Welcome to AZENT's Guideline Updates, Episode G9, GI Bleeding. I am Dr. Z. KC is here with me. Educational only, not individual medical advice.
Dr. Z, I am going to be honest. Every time I see Melina in the ED note, my instinct is admit call GI scope in the morning. Is that still the right answer?
Sometimes, but the ACG 2021 Upper GI Bleeding Guideline and the ACG 2023 Lower GI Bleeding Guideline both push toward risk stratification at triage before you make that call. Not everyone with GI bleeding needs to be admitted.
Let us start with upper GI bleeding. What is the Glasgow-Blatchford score?
It is a risk stratification tool calculated at ED presentation. It uses BUN, hemoglobin, systolic blood pressure, heart rate, the presence of melena, syncope, hepatic disease, and cardiac failure. A score of 0 to 1 identifies very low-risk patients who can be discharged with outpatient upper endoscopy follow-up. They do not require inpatient admission.
Walk me through an example.
Let us say you have a patient with BUN of 12, hemoglobin of 13, systolic blood pressure 125, heart rate 68, no melena, no syncope, no liver disease. That patient likely scores 0 or 1. Per the guideline, you could discuss outpatient management. Compare that to the patient who comes in with hemoglobin of 7, BUN of 30, melena, and heart rate of 110. That patient has a high GBS score and needs admission.
At what point do they get the endoscopy?
Within 24 hours for admitted patients. Not emergent. Not in the middle of the night unless the patient is hemodynamically unstable and not responding to resuscitation. The evidence shows that urgent but not emergent endoscopy within 24 hours has equivalent outcomes to very early scope for stable patients.
Erythromycin before the scope. I have heard about this but never understood why.
Pre-endoscopic erythromycin, 250 milligrams for 20 to 90 minutes before endoscopy, promotes gastric motility and clears the stomach of blood and clots. It improves visualization, reduces the need for a second procedure, and shortens the scope time. It is a conditional recommendation in the 2021 guideline, easy to implement and often forgotten.
What about PPI before the scope?
The guideline reflects genuine uncertainty here. Pre-endoscopic PPI does not clearly improve clinical outcomes like rebleeding, mortality, or need for surgery. Some clinicians use it empirically. The evidence does not strongly support it, but the guideline does not strongly recommend against it either. Post-endoscopic PPI after hemostasis is a different story. High dose for 3 days, then twice daily oral through day 14.
Transfusion. My attending always wants hemoglobin above 9.
The data does not support that. A restrictive transfusion strategy targeting hemoglobin below 7 or below 8 for patients with pre-existing cardiovascular disease is associated with lower mortality and lower rebleeding rates compared to liberal transfusion. The trial evidence is consistent and the guideline is firm on this. Transfusing to 9 is not evidence-based in stable GI bleeding and may actually worsen outcomes.
Now lower GI bleeding. This feels different.
It is. The ACG 2023 Lower GI guideline introduces the Oakland score for risk stratification, though it acknowledges this tool has limited large-scale validation. The big practice change is colonoscopy timing.
Walk me through that.
For hemodynamically stable patients with lower GI bleeding, colonoscopy within 14 days is as effective as colonoscopy within 24 hours. There is no mortality benefit to rushing a stable patient to the scope table on a Sunday night. The prep matters. A proper preparation improves visualization and diagnostic yield.
When do I actually need urgent intervention in lower GI bleeding?
Hemodynamic instability that does not respond to resuscitation. In that case, CT angiography first. CTA has about 90% sensitivity for localizing the bleeding source, and about 80% of patients with a negative CTA do not rebleed. CTA guides the decision for angioembolization or surgical referral.
Tranexamic acid for lower GI bleeding. I have seen it ordered.
Do not give it. The 2023 guideline recommends against tranexamic acid for lower GI bleeding. The data shows no benefit and it increases the risk of thromboembolic events and seizures. This is a hard stop recommendation. It is not a conditional recommendation. It is no.
What about anticoagulants during and after GI bleeding?
Aspirin for secondary cardiovascular prevention should generally be continued through a GI bleed unless the patient is actively hemorrhaging and hemodynamically unstable. The CV risk of stopping aspirin often outweighs the incremental bleeding risk. Dose should be held. Warfarin should be held. Reversal agents like andexanet alpha or idarucizumab are reserved for life-threatening, hemodynamically unstable bleeding. Not every anticoagulated GI bleed needs reversal.
And restarting anticoagulation?
Within 7 days for most lower GI bleed patients after hemostasis is confirmed, assuming the indication for anticoagulation is active. This is a multidisciplinary conversation for high-risk cases. GI, cardiology, hematology, depending on the indication. The discharge summary should document that plan explicitly.
Variceal bleeding. Special scenario.
Immediate octreotide. Antibiotics for all variceal bleeds, ciprofloxacin or ceftriaxone. And endoscopic variceal ligation within 12 hours. The antibiotics data is among the strongest in hepatology. It reduces infection, bacteremia, and mortality. This should not be an afterthought.
3 take-homes.
1. Calculate the Glasgow-Blatchford score at triage for upper GI bleeding. A score of 0 to 1 supports outpatient management. 2. Transfuse a hemoglobin below 7 or below 8 for cardiovascular disease. Not to 9. 3. No tranexamic acid in lower GI bleeding, and colonoscopy within 14 days is fine for stable lower GI bleeding.
G9 down. Last episode is G10, pneumonia with drug-resistant pathogens. The MRSA nasal PCR episode.
And the one that will hopefully stop the reflexive vancomycin plus piptazo order. See you in episode G10 on AZENTs.